Welcome. In today's video, I'm going to teach you everything you need to know about major depressive disorder for your exam. We're going to cover presentation, we're going to cover causes, diagnosis, treatment, mnemonics, and everything you may encounter during your exam. So let's begin. First thing, we're going to start with a question. A 35-year-old woman reports 3-week history of depressed mood, loss of interest in activity, insomnia, fatigue, and feeling of worthlessness. She denies past manic episodes. Which is the most appropriate initial treatment? Lithium, sertraline, haloperidol, or electroconvulsive therapy? And if you don't know the answer to this question, as always, don't worry about it. You will know all these answered by the end of the video. So let's begin. What is major depressive disorder? Well, it is characterized by one or more major depressive episodes that must be lasting greater than 2 weeks. That is a key factor. It has to be present for more than 2 weeks. The featuring going to be persistent low mood or loss of interest or pleasure, as known as anhedonia, along with cognitive and somatic symptoms. Also known somatic symptoms, it could be in a question stem, so they may ask you which of these symptoms is considered somatic symptoms, and those will be fatigue, feeling of worthlessness, sleep disturbance, and appetite changes. This disease or disorder, it will significantly impair their social, occupational, and other important areas of functioning. MDD can be recurrent and is diagnosed after excluding substance use and medical causes. So the mnemonic that I have for major depressive disorder is MDD. I just remember as most days down. MDD, most days down. Persistent sadness and loss of interest. Exam tip. So you're going to be looking for at least 5 symptoms lasting greater than 2 weeks, including depressed mode or anhedonia. Remember mnemonic SIGECAPS, which we'll cover here shortly, and do not confuse this with bipolar disorder. MDD has no history of manic or hypomanic episodes, which are required for bipolar disorders. They do not confuse this with grief. This will be mood symptoms fluctuate and are likely due to some kind of loss or self-esteem is preserved in those cases. And dysthymia, which is persistent depressive disorder, is going to be chronic and it's going to be lasting greater than 2 years. And MDD, you're looking at something in a shorter duration. It has to be present for more than 2 weeks. So this is a good time to tell you this lecture is present to you by PA Psych EOR book, in which we cover 57 topics on a blueprint with 120 mock exam questions to help you study smarter, not harder. This book is created because I did not have something like this when I was in PA school, and I think this would be a game changer for me, and I think it will be for you as well. So do check it out. So what is the MDD criteria for major depressive disorder? Remember the mnemonic SIGECAPS. It is necessary to have 5 symptoms lasting greater than 2 weeks. They must include depressed mode or anhedonia. S stands for sleep, insomnia or hypersomnia. I for interest. They're going to be having a loss of interest or pleasure. G is for guilt or worthlessness. They're going to be expressing thoughts of being worthless, excessive guilt. E is for energy. They're going to have fatigue or low energy. C stands for concentration. They're going to present with poor concentration. A is for appetite, decreased or increased appetite. P is for psychomotor, observe agitation or retardation. And S is a big one, is suicidality, thoughts of death, suicidal ideations, or even attempt. Diagnostic rule will be greater than 2 weeks and 5+ symptoms. At least one must be depressed mode, causes distress and impairment, and this is going to be not due to the substance or medical illnesses. So for additional notes, symptoms must cause clinically significant distress, cannot be due to the substance or medical conditions, and it's not better explained by schizoaffective disorder, schizophrenia, or other psychotic disorders. What is the causes of MDD? Well, causes are going to be genetic vulnerability with the family history, neurotransmitter imbalance. You're going to be looking for serotonin, norepinephrine, and dopamine. Psychosocial stressors and trauma can trigger MDD, and medical conditions such as hypothyroidism or chronic illness. So the question stem can ask you which of these medical conditions is linked to major depressive disorder, and in that case, the answer is hypothyroidism. Exam tip, rule out organic causes or substance use before diagnosing somebody with MDD. Don't confuse this with substance-induced mode disorders. What is their clinical presentation and their physical exam? So this is something you encounter during your psych rotations or just during your exam. So they're going to be depressed mode or a loss of interest. They're going to have sleep issues, psychomotor changes, agitation, retardations. They're going to be fatigued. They're going to have that extreme feeling of worthlessness, of guilt. That's a big one. I'll look for that in the question stem. And they're going to have impaired concentration, recurrent thoughts of death or suicide. Assess suicide risk throughout in all patients with MDD. Don't confuse this with a normal sadness or adjustment disorders without severe impairment. That's what's going to be differentiating sadness and adjustment disorder from MDD. Look for that severe impairment. What is the treatment? Well, first line treatment for MDD is SSRIs, such as fluoxetine or sertraline. Psychotherapy, CBT, or interpersonal therapy could be adjunctive. Consider augmenting with atypical antipsychotic if inadequate response to SSRIs, and electroconvulsive therapy for severe refractory or psychotic depression in MDD patients. If the patient has suicidal thoughts and is at increased risk of suicide, you should be hospitalizing these patients. So that could be something that could easily be in a question stem. They're going to tell you patients feeling worthless, they have issues with sleep, they're agitated, but they also expressing suicidal thoughts and they're increased risk for actually doing this. They have means to it, and the question stem would ask you what is the next best step in treatment for these patients, and that would be hospitalization. Memory hook, mood train, feeling down. Hop on search or flow train to happy town. So if I think about MDD and what is the treatment option, I just think most days down, feeling down. I need to hop on this searcher train to happy town. So searcher reminds me of sertraline or fluoxetine. So you can come up with your own memory hook. I strongly advise that, but for me, I just think most days down, I need to hop on the search or flow train to happy town. Exam tip: antidepressants may take 4 to 6 weeks to show some kind of effect, so monitor these patients for worsening suicidal irritations early in treatment. Don't confuse this with starting benzodiazepine for depression. They're not effective and it's a risk dependence. So let's summarize the high yield facts about major depressive disorder. You're going to be requiring at least 5 symptoms that include depressed mode that are lasting greater than 2 weeks. Common symptoms are going to include sleep and appetite changes, fatigue, guilt, and impaired concentration. SSRIs are first line treatment. Hop on a search or flow train. Psychotherapy is essential adjunct, and assess for a suicide risk carefully in all of the patients. Exam tip: rule out bipolar disorder before starting antidepressants. Let's go back to our question. A 35-year-old woman reports a 3-week history of depressed mode, loss of interest in activity, insomnia, fatigue, and feeling of worthlessness. She denies past manic episodes. Which is the most appropriate initial treatment? Lithium, sertraline, haloperidol, or electroconvulsive therapy. So, hop on a search or flow train. So you know you're dealing with MDD. The first line treatment is SSRI. So sertraline is the correct answer. Lithium is a mood stabilizer, good for bipolar disorder, not for MDD. Haloperidol is also antipsychotic. It's not a first line for depression without psychosis. And ECT is reserved for severe, treatment-resistant, or psychotic depression. So I hope you find this video helpful. I advise you to check out a book again. It will help you study smarter, study faster, save the time, spend it with your loved ones. And as always, I'll see you guys in the next video. Good luck on your exam.